We'd like to thank you for attending our breakfast symposium this morning on Her Heart Matters, Preventing, Diagnosing, and Treating Heart Failure in Women. I have a little housekeeping items I need to go over with everyone since this is an accredited CE program. This activity is provided by the American Association of Heart Failure Nurses. The American Association of Heart Failure Nurses is accredited as a provider of a continuing nursing education by the American Nurses Credentialing Centers Commission on Accreditation. This program is approved for 1.75 contact hours of continuing education through the ANCC. Faculty disclosures are provided in the course syllabus as well as will be on the screen during the presentation. And this activity is supported by Arbor Pharmaceuticals. We have a couple of fabulous speakers to talk with you today. Our first is Dr. Carol Watson. She received her medical degree from Harvard Medical School, magna cum laude, and completed a residency and internship in internal medicine and fellowship in cardiology at UCLA. She is currently the professor of medicine in UCLA's Division of Cardiology, and she is the director of the UCLA Barbra Streisand Women's Heart Health Program. In addition, we have Kim Newlin. She earned her BS degree in exercise physiology at UC Davis, and she completed her RN CNS program at UC San Francisco and her gerontology adult nurse practitioner postmaster's program through the University of Massachusetts at Boston. She is the clinical manager, cardiac and pulmonary rehabilitation, cardiovascular and pulmonary transitional care teams at Sutter-Roseville Medical Center, and she manages the Sutter-Roseville Medical Center Heart Health Clinic. They will be presenting for until about 7:45, and then we will be doing a Q&A, and myself and my colleague will be walking around with handheld mics. We invite you to ask questions. This is supposed to be very interactive. We want you to walk away with a lot of great pearls and things that you can take back to your practices to help improve the quality of life or help save the life of your patients that you work with. So without further ado, I'm going to turn the podium over to Dr. Watson.
Right. Good morning, everyone. Okay, so it's a pleasure to be here, and I'm talking about a topic which I have a lot of respect for because we see it all the time and it impacts our patients and our patients' lives. I'm at heart a preventive cardiologist, so I like to prevent disease, but when we don't, the end stage of what you see is heart failure, and so we need to know how to manage that. This is the heart failure in women I'd like to talk about. And as you know, fun fact, scientists have proven that approximately half of all human beings alive are women. So we actually need to know about how to treat disease in women as well as in men. Many of us learned about the 70-kilogram man while we're doing our training. Turns out that there are 70-kilogram women, 60-kilogram women. They're sort of all body types, sizes, shapes, sexes. So we need to know what to do for all of our patients. These are my disclosures. I'm going to talk about the epidemiology, classification, and prognosis of heart failure. That will be quick. Then we're going to dive down into heart failure in women specifically and talk about the scope of the problem. Then I'd like to talk about management of heart failure. Then we're going to talk about prevention of heart failure, and then finally we'll talk about some heart failure syndromes that are unique to women. Okay, so about the epidemiology. As you know, we're a large population and we're getting older. So if you look at heart failure deaths by age, you can see that the number of deaths increase as the age of the patient increases. The trajectory of increase from 1976 to 1980 is shown in the blue line. You can see in more recent years there's been a sharper increase. So that means that we're getting older, we're having more mortality from heart failure. Heart failure is prevalent in both men and women. And as you can see here, as I mentioned, it's age-related. So as the age increases, the heart failure incidence increases. And as you see, for many of the time periods, men outstrip women, but by the time you get to the very older groups, women and men reach pretty much parity. So there is equal number of heart failure cases in older women, and because women tend to live longer than men, the overall prevalence of heart failure is about the same in men and women. Now I'm going to talk briefly about the classification. The classification system is that we use currently, there are actually two. The older one that has been used forever is called the New York Heart Association Functional Class. That's a completely functional system. So basically, all of the patients that are classified by New York Heart Association Functional Class have a decreased ejection fraction, and then you go by how symptomatic they are. So someone who has a decreased ejection fraction, less than 40%, and is completely well, is New York Heart Association Functional Class 1. They're completely asymptomatic. Now, when you get to New York Heart Association Class 2, that's when you start having symptoms. But it's symptoms really at moderate exertion, when you take a hike or when you go upstairs. They're pretty well, but when they do more than average exertion, they get symptoms. Class 3 patients, they are symptomatic really at minimal exertion. So even when they're doing, light housework, they get symptomatic, or walking around the block. And then class 4, these are patients that are severely symptomatic. They are what we call the end stages of heart failure. Now, about 20 years ago, the ACC and the AHA came up with a new classification system called the staging system. And I really like the staging system because this was basically trying to look at the pathophysiologic stage of the disease rather than just symptoms. So remember I told you in the New York Heart Association classification, everybody already has decreased ejection fraction. But in the staging system, the first two stages, A and B, are patients that are completely asymptomatic, and actually in stage A, they don't have any structural heart disease at all. But what they have are risk factors for progression to structural heart disease. So the whole idea of bringing forth this classification system was to let you know that a lot of heart failure cases really are preventable. So when you see a patient with hypertension, for example, that's a patient with hypertension, yes, and we treat that, but that's also a stage A heart failure patient. So I don't just think of my hypertension patients as hypertension patients, I think of them as pre-heart failure patients if I don't do something right. Stage B now, they've started to have some structural abnormalities in their heart, but again, they're completely asymptomatic. It's kind of like New York Heart Association Functional Class 1. By the time you get to stage C and D, that's when you start to get symptomatic. So the patients with stage C, they have heart disease, they have decreased ejection fraction or some structural abnormality, and they also have symptoms. And then by stage D, again, that's the refractory heart failure patient. We also have two unique subtypes of heart failure. There's HFrEF and HFpEF. HFrEF stands for heart failure with reduced ejection fraction. That's typically what we think of as the low ejection fraction patient. So the heart just doesn't squeeze well enough to pump blood to the rest of the body. And that's what we have also thought of as systolic heart failure, that big boggy heart. But there's also HFpEF. HFpEF is heart failure with preserved ejection fraction. And those are patients who can squeeze just fine. Their hearts squeeze absolutely great, but they can't relax. And if your heart can't relax, your heart can't fill. And if your heart can't fill, there's nothing to pump. So those patients end up having heart failure on the basis of an inability of the heart to relax. So when you do their echocardiogram, their ejection fraction usually looks supranormal. It looks great. It looks like 70%. But the heart squeeze is great. It just cannot relax. And when it can't relax, it can't fill. What's interesting is HFrEF is more common in men. So the reduced ejection fraction heart failure is more common in men. HFpEF is more common in women. While we have a lot of therapies that we know improve survival with HFrEF, we actually have nothing that improves survival in HFpEF. So when I think of heart failure management, I always think of two things. Our two separate goals are to make patients feel better, but to also make them live longer. So for HFrEF, we have a lot of drugs that make patients feel better and make them live longer. For HFpEF, we have some drugs that can make them feel better, but we have no medications that have been shown to make them live longer. And this is just a kind of complicated slide, but all it's meant to show you are heart failure mortality trends from the period 1950 through 1999. And each line shows you a successive different time period. All you need to know is that for both men and women, in the course of that 50-year period, heart failure mortality trends have improved a little bit, but they're really still awful. So when you look at the time after the onset of heart failure diagnosis to the about 20% survival rate, it's about 10 years. And again, we've had so many great medical breakthroughs and therapies, but despite that, the 10-year mortality is still about 80% for both men and women. So despite dramatic improvements in heart failure management, survival is still dismal. So let's talk about the specifics of heart failure in women, the scope of the problem. Well, as I mentioned, about half of the world is women, and it turns out about half of heart failure cases also occur in women. Unfortunately, when you look at the clinical trials that we've done in heart failure, looking at what therapies work and what drugs and what doses, very few women, only about 20% of these studies have enrolled women. And in fact, the magnitude of heart failure survival over the past several decades has been less pronounced in women than men. So we're doing better in some ways and not better in other ways. And for women, we don't have the same sort of benefit from the increased medications and therapies that we've seen in men. Women with heart failure tend to be older, have more comorbidities, and are more likely to have HFpEF, heart failure with preserved ejection fraction. And again, heart failure medications appear to provide the same benefits in women and men, but that's a leap of faith. We think that's true, but because most clinical trials have enrolled inadequate numbers of women, we don't know that that's true in all cases. Now, the risk factors for development of heart failure also differ by sex. As I mentioned, hypertension and diabetes appear to be stronger risk factors for the development of heart failure in women as compared to men, especially in younger women. So when you look at younger women who are developing heart failure, they tend to have a disproportionate burden of hypertension and/or diabetes. Let's talk about management now. So we'll start by talking about HFrEF, heart failure with reduced ejection fraction. That is the type of heart failure that we've studied for decades, and almost all of our therapies have been developed to attack heart failure with reduced ejection fraction. But as I mentioned before, many of these trials did not enroll adequate numbers of women. So these are some of the seminal trials in heart failure management: the SOLVE trial, the CHARM trial, the SHIFT trial, the EMPhASIS trial, the PARADIGM trial. The PARADIGM trial was just published 2.5 years ago. And as you see, the number or the percentage of women that were enrolled in those trials is only about 20%. So even as recently as 2012, we're only enrolling about 22% of women in these heart failure trials. So again, we take that, everything we know, we think it works well in women just like it does in men, but again, some of that's a leap of faith. But these are the drugs that we have been shown by clinical trials to reduce mortality in heart failure with reduced ejection fraction, HFrEF. Angiotensin receptor blockers, ACE inhibitors, beta blockers, and mineralocorticoid receptor antagonists like spironolactone. And so when you think about, again, we're thinking about drugs that make people feel better and drugs that make people live longer. So the medications that will be used in virtually all of your HFrEF patients are diuretics. They don't make anyone live longer, but they certainly make people feel better. Beta blockers help people live longer. ACE inhibitors or ARBs help people live longer. Now, the common medications that were used in virtually everyone with heart failure with reduced ejection fraction were beta blockers and ACE inhibitors, or ARBs. But just this year, about a month ago, the American College of Cardiology and the American Heart Association came out with updated guidelines for the management of heart failure, and they actually recommended switching patients who are already on an ARB or an ACE inhibitor to this new medication, which is known as ARNI, angiotensin receptor neprilysin inhibitor, sacubitril/valsartan, and I'll talk about that in a second. There are other medications that we have available to use in select patient populations, like aldosterone antagonists, hydralazine isosorbide, digoxin, and Ivabradine. And I'll talk specifically about sacubitril/valsartan, I'll talk about hydralazine isosorbide, and I'll talk about Ivabradine, because those are the newer agents that we have available for us. Okay, I'm going to start by talking about sacubitril/valsartan, and we'll do that by talking about the pathophysiology behind neprilysin. So we have a number of endogenous vasodilators in our body. So BNP, which is that hormone that we measure to diagnose heart failure, it's actually one of our endogenous vasodilators. And remember, heart failure, I'm going to give you my horse and a cart analogy. Imagine you have this beloved horse. It's been used for years to carry your water up the hill to your home, but this horse is getting old and tired. So the horse is having more and more trouble carrying that water up that hill. So think of that whole beloved horse as your failing heart. Now the cart and what it's carrying, the water, is preload. That is the amount of blood that you have. And because the horse is getting so tired, you have to decrease your blood volume with something like a diuretic, get rid of some of that water, to make it easier for that horse to get up the hill. The hill is actually like afterload. It's like what our heart has to pump against. That's what the horse has to climb against. And because the horse is getting old, you can't really climb up a high hill anymore. So you need to lower the afterload. And we do that with vasodilators like ACE inhibitors and ARBs. But our body has a number of endogenous vasodilators too, like BNP, ANP. And these endogenous vasodilators help a failing heart perform better. So we want to keep all these endogenous vasodilators around. But it turns out there's this evil enzyme called neprilysin, which goes around chewing up all of our endogenous vasodilators. So when you have neprilysin around, your endogenous vasodilators are chewed up, gotten rid of, and so you don't have the benefit of those vasodilators. So the idea behind neprilysin inhibitor was if you can get rid of neprilysin, you'll stop chewing these things up. And remember, these peptides are there for a reason. They help to counter the maladaptive mechanisms in heart failure, so preserving them is crucial. So if you have a neprilysin inhibitor, what you'll do is you'll stop chewing up those vasodilators, and you'll preserve more of them, and hopefully the heart will perform better. That was the whole idea behind neprilysin inhibition. This whole theory was tested in the Paradigm heart failure trial. This was a trial of over 8,000 patients, all of whom had HFrEF, reduced heart ejection fraction. They were all on standard heart failure medications, and they were randomized, instead of an ACE inhibitor, they were randomized either to sacubitril/valsartan or enalapril, and then followed up for 27 months. And as you can see, the group that was randomized to the sacubitril/valsartan, the red line, had reduced cardiovascular death or hospitalization, and that was statistically significant. I think there's about 6 or 8 zeros before this after the p-value. And when you look at a lot of different outcomes, so heart failure, hospitalization, mortality, all were improved. Now, when you think about any drug, you have to think about not just the benefits, but also the risks. And there were some risks with this. If you look at sacubitril valsartan as compared to enalapril, there was more hypotension. There was also more hyperkalemia. And, so you have to worry about these things, but overall, the benefits outweighed the risks, and so it was felt to be beneficial. And when you look at how this therapy stacked up to other therapies we use in heart failure, it looked really beneficial. So with just angiotensin receptor blockers, you get about a 15% mortality reduction. With ACE inhibitors alone, you get about an 18% mortality reduction. If you use a combination of a neprilysin inhibitor and an angiotensin receptor blocker, you get about an additional 20% mortality reduction, so beneficial. And because of that, this was honestly the fastest I heard of a new trial making it into guidelines. So the update of the heart failure guidelines was published just earlier this year, and they said, in patients with chronic symptomatic HFrEF, reduced ejection fraction heart failure, New York Heart Association class 2 or 3, who tolerate an ACE inhibitor or an ARB, replacement by an ARNI, the angiotensin receptor blocker neprilysin inhibitor, that's sacubitril valsartan, is recommended to further reduce morbidity and mortality, and that got a class 1 recommendation, level of evidence A. So honestly, that was probably about the quickest I saw a new therapy get into the new heart failure guidelines. The trade name for the sacubitril valsartan is Entresto, and it is currently available. We'll remind you how, just like ACE inhibitors and ARBs, it is contraindicated in pregnant women because it does contain an ARB. This is the medication now. It comes in 3 doses, and you do a gradual dose titration upward, and it's indicated to reduce the risk of cardiovascular death and hospitalization for heart failure in patients with chronic heart failure, New York Heart Association class 2 to 4, and reduced ejection fraction. Okay, now that was sacubitril valsartan. Now I'd like to talk about another combination medication, isosorbide dinitrate and hydralazine. Now this is a therapy that was first tested about 30 years ago in the VHF trial. In the VHF trial, that was one of the old heart failure trials, they used a combination of isosorbide dinitrate or hydralazine compared to enalapril to see which one would reduce heart failure deaths the most and mortality and morbidity. In that study, overall, they found that the ACE inhibitor reduced morbidity and mortality better than the combination of isosorbide dinitrate and hydralazine. So that's when ACE inhibitors became our go-to drugs in heart failure. But when Jay Cohn, who was the principal investigator of that study, did the subgroup analysis, he found that in the African American patients that were enrolled in that trial, they did much better on isosorbide dinitrate hydralazine than on an ACE inhibitor. Because they were only a minority of the enrollees in the trial, the benefit was sort of washed out by the greater benefit in the non-African American population for ACE inhibitors. So that's why ACE inhibitors became our go-to drugs. But Jay Cohn always had in the back of his head that finding. He said there's something there. And so about 20 years later, he came back and did this trial called the AHF trial, the African American Heart Failure Trial. And he said, I'm going to use this combination of hydralazine and isosorbide dinitrate on top of an ACE inhibitor in African American patients only. So these were 1,000 self-identified African American patients. They all had stable New York Heart Association class 3 to 4 heart failure. They were all on standard heart failure medications, including beta blockers and ACE inhibitors. They were then randomized to this combination of isosorbide dinitrate and hydralazine, also known as Bidil or placebo. When they did that, they found that the reduction in mortality in those who were on the hydralazine isosorbide combination was significant, about 47%. That's really hitting it out of the ballpark. We really don't see mortality reductions that are that impressive in most of our clinical trials. So 43% mortality reduction. Now, the AF trial had 40% women. That was actually really good. Remember, most of the trials I've shown you have about 20% women. So this trial actually had a larger proportion of women than any other heart failure trial. So we can feel pretty darn confident that these results translate to women as well as to men. So these also are in the guidelines. So from the 2013 ACC/AHA guidelines on heart failure, it says that the combination of hydralazine and isosorbide dinitrate is recommended for African Americans with New York Heart Association class 3 to 4 HFrEF, reduced ejection fraction, on guideline-directed medical therapy. And that's a class 1 level recommendation with level of evidence A. They also say a combination of hydralazine and isosorbide can be useful in patients with HFrEF who cannot be given an ACE inhibitor or an ARB. So even if they're not African American, if they can't get on the gold standard therapy, this is recommended. And that's the medication. You titrate up, go up 1 tablet 3 times daily, up to 2 tablets 3 times daily. Okay. The FDA, so, Isordil, or isosorbide dinitrate, is available as a standalone pill, and hydralazine is available as a standalone pill. But the FDA says they has not approved any drug product under this Section 505 that is equivalent to Bidil. So basically, what they're saying is this study was performed with this combination medication, and so we can't know that you can extrapolate the outcomes to any other non-proprietary formulation. Last medication I want to talk to you about is Ivabradine. Ivabradine was studied in the HFrEF trial. So let me go back to that horse and cart analogy. So say I have my old failing horse trying to get that cart up the hill. What if I say, I got to get there really fast, let me start galloping him? Well, he's going to tire out a lot faster and not do well. I need to send him at a slow, steady pace. That's why we use beta blockers in heart failure. Slowing the heart down will help preserve the function for longer. But as you know, there are some patients who just cannot get on enough beta blocker to get their heart rate to where we'd like it. There's a new medication called Ivabradine, which is an inhibitor of the funny channel in the sinus node. So basically, the sinus node is the electrical pacemaker of the heart, tells your heart how fast and when to beat. When you inhibit this funny channel, it slows that pacemaker down. So Ivabradine is a medication that will reduce the heart rate without affecting blood pressure or other hemodynamic parameters. When it was studied in patients with heart failure on standard medical therapy and maximally tolerated beta blocker who remained with a heart rate above 75, then they found that Ivabradine in that setting reduced the risk of cardiovascular death or hospitalization for heart failure, as you see here. Now, so this is a really good therapy that we can use in our patients who we just can't get the heart rate down low enough because they either cannot tolerate the beta blocker at high enough doses, maybe because of reactive airway disease, or maybe because of hypotension, but we can't get them on the amount of beta blocker we want them on. So these are patients on maximally tolerated beta blocker. If their heart rate still remains elevated and you use Ivabradine on top of the beta blocker, you get a reduction in death and hospitalization. And this is a busy slide, but I just want to show you that the heart rate achieved was related to the best survival. So if your heart rate was above 75, that's the red line, you had the highest rate of heart failure, hospitalization, or mortality. It went down, if the blue bars, if you got it between 70 and 75 or 65 and 70, and it was best in the yellow, the sort of salmon-colored line on the bottom, if you got the heart rate below 60. So the guidelines also introduced, about a month ago, introduced Ivabradine into the guidelines. They say, Ivabradine can be beneficial to reduce heart failure hospitalization for patients with symptomatic stable chronic HFrEF, heart failure with reduced ejection fraction, who are receiving beta blockers at maximum tolerated doses and who are in sinus rhythm with a heart rate of 70 beats per minute or greater. And this is what Ivabradine looks like. You start off at a low dose, 5 milligrams twice daily, and then you actually increase it up as tolerated by the heart rate. Now, this is from the package insert. It says you should not become pregnant while taking Ivabradine. Women who are able to get pregnant must use birth control when taking Ivabradine. So again, heart failure management, you have medications that virtually all your patients will be using, and then you have medications that some of your patients would be using, and then you have medications that really you should get rid of if you at all possible can. And these are drugs that have been shown to be potentially harmful in heart failure patients. I would point out to you, NSAIDs are particularly nefarious and sneaky because many of our patients are taking Motrin over the counter. But in patients with heart failure, it causes retention of salt and water, sodium and water, so they hold on to fluid from that basis. And it also can precipitate renal failure in the setting of heart failure. A lot of devices for end-stage heart failure, like the ICD, the CRT, things like that. And I gotta say, most of those device trials enrolled even fewer women than the medication trials. And some of these devices don't even fit into the chest of a woman. So there's some more data that we need to develop in that sense. So studies have shown that women benefit as much as or to a greater extent than men, but unfortunately studies also show that women are much less likely to be given appropriate device therapy than men. Okay, I want to finish up by talking about heart failure with preserved ejection fraction. Remember, that's the one where the heart beats, squeezes just fine, but it can't relax. That was formerly called diastolic heart failure. The diagnosis of heart failure with preserved ejection fraction is based on the clinical finding of congestive heart failure with the echocardiography findings of preserved left ventricular ejection fraction and the absence of valvular abnormalities. That's from the ACC AHA guidelines. I would show you, look at the first column, which is patients with reduced ejection fraction, next to the third column, which are patients with preserved ejection fraction. The standard patient that you see with HFpEF will be an older woman with long-standing hypertension. Classic case, older woman, long-standing hypertension. And again, we used to think that, well, the heart squeezes fine, so it's got to be better outcomes, right? Well, when they looked at the studies, actually, the mortality from HFpEF is exactly the same as the mortality from HFrEF. You can see those two curves are almost superimposable. And again, because we don't have good medications to make people with HFpEF live longer, that might be one of the reasons why we're not seeing better outcomes. So unlike HFrEF, where multiple medications have been shown to improve survival, in HFpEF, no medications have been shown to improve survival. So what do? Well, if I can't make you live longer, I can at least make you feel better. So I'm going to try to manage your volume, have you check in your weight daily. You don't want to give too many diuretics because diuretics will all activate the renin-angiotensin-aldosterone system. We don't want to do that. But because these patients are so symptomatic, you do have to diurese them. But you want to avoid over-diuresis. Again, avoid any harmful medications, especially NSAIDs. Treat the underlying hypertension. tachycardia, diabetes, chronic kidney disease, coronary artery disease, and also teach self-management. So all my patients with heart failure have to buy a reliable scale, and they get up and they use my mantra, same scale, same time, same place. Weigh yourself every day, and when the weight goes up, you have to let one of us know. Okay, finally I want to talk about prevention of heart failure. So again, the staging classification really was brought about to put a new emphasis on the evolution and progression of heart failure with a greater focus on risk factors and prevention so that the disease process doesn't continue on. This new classification system recognized that there are established risk factors and structural prerequisites for the development of heart failure, and if you could intervene before heart failure develops, you will have much better outcomes. So much of heart failure is preventable. So again, when you think about the stage A patient, that's the patient who has completely structurally normal heart, but they have a lot of risk factors that make you think they might develop heart failure in the future. Things like hypertension, coronary disease, diabetes, a family history of cardiomyopathy, a lot of different things. You need to get really aggressive at treating those risk factors so that patient never develops heart failure. And again, as I said, hypertension is a really important risk factor for heart failure, especially in women. As you see, the population attributable risk for developing heart failure in women, shown in red there, versus men, shown in blue, hypertension is a more prominent risk factor for women. Other things like myocardial infarction are more prominent in men, but hypertension is a really, really important risk factor in women. So Framingham data shows increased heart failure in adults with diabetes. It's about a 2-fold increased risk in men, but it's a 5-fold increase in women. National Registry of about 100,000 patients hospitalized with heart failure showed that about 44% of them had diabetes, so it's really common. All right, and finally, I just want to talk about, really quickly, some heart failure syndromes that are unique to women. Stress is not an equal opportunity risk factor. We call them the SAD risk factors. Stress, anxiety, and depression are actually more prominent risk factors in women than men, and stress in general is just more harmful for women than men. There's a classic heart failure syndrome called stress-induced cardiomyopathy, also known as Takotsubo cardiomyopathy, also known as broken heart syndrome. So it's usually someone has what they call a lifetime stressor, death of a child, something, major earthquake, something like that. 90% of these cases are postmenopausal women. So what they have this preceding lifetime crisis, and they present just like someone is having an acute myocardial infarction, except when you do their angiogram, you see that their coronary arteries look completely normal, but their heart function does not. So on the left is a normal left ventriculogram in diastole when the heart is resting. When it's squeezing, the whole part of the heart is supposed to squeeze inward, but you see only one little part over there on the right is squeezing in, and the rest of it is just ballooning outward. It's called this classic apical ballooning. And these patients present like they're having a heart attack. They present with heart failure. The good news is most of these patients will recover, but it's something that's unique or much more likely to occur in women. The reason it's called Takotsubo cardiomyopathy is because this Japanese fishing vessel, that's called a Takotsubo, looks just like the heart. Another syndrome that's unique to women are women who are status post breast cancer treatment. There are many of our chemotherapeutic agents which are cardiotoxic. They cause more death of myocytes, so they can cause reduced ejection fraction heart failure. And there are other drugs that don't directly cause toxicity, but can cause salt and water retention, so they get heart failure on that basis. The drug Herceptin, which was just a godsend for some breast cancer patients, has been known to cause cardiotoxicity and heart failure in women. So some anti-cancer treatments may cause temporary heart damage by weakening the heart muscle. These treatments include, anthracyclines, newer medications like Herceptin, and things like that. And also chest radiation can cause damage to the heart and lead to heart failure. What we know is that in patients who have taken Herceptin, that's shown there as the red line, they have increased risk of heart failure and cardiac events as compared to breast cancer patients who don't take Herceptin. That's the blue line. We also know that there's many people who will take Herceptin, but there are things we can do to try to ameliorate some of their risk. So if we get them on standard heart failure medications and good medications, they will actually end up having preservation of their ejection fraction. So what you see on the left is the ejection fraction before they got Herceptin. Then the second bar is after Herceptin. But if you then put them on good heart failure medications, you see the ejection fraction rises again back to the baseline. And given standard medications for heart failure, as you see in this slide as well, is very important for reducing the risk of severe and long-standing ejection fraction damage. Now, peripartum cardiomyopathy is the last unique cardiomyopathy for women. That is really tragic, where the left ventricle develops dysfunction in the prepartum, right around the time of the birth, or the early postpartum period. It's really rare. That's good. But, it's devastating when it happens. Risk factors: African Americans more likely, older age, multi-fetus pregnancies, and pregnancy-associated hypertension. Fortunately, again, most women will recover, but this is a tragic outcome. And what you need to do in these women is get them on standard heart failure medication. But remember, when you do that, then they can no longer breastfeed and they can't get pregnant again, things like that. But if you get them on appropriate therapy, most of them will do really well. Now, healthy lifestyle, and we're going to talk a lot about that, is really key to trying to prevent heart failure. This is data from the Women's Health Initiative study, and it shows that a healthy lifestyle score, that means healthy eating, healthy weight, not smoking, lots of physical activity, is really strongly associated with protection from developing heart failure. So the higher your healthier diet score is, the lower your risk. So in conclusion, heart failure is common and the prevalence is increasing. Heart failure affects both men and women in approximately equal numbers, and unfortunately we don't have as much data on heart failure in women and what therapies work though. The risk factors, predictors, and pathophysiology of heart failure may be different between men and women, and again, women are just underrepresented. But women also suffer these unique heart failure syndromes, which we have to be aware of as well. I just want to finish up by saying, prevention of heart failure is the only way to go, because if we keep on doing what we've always done, we'll keep on getting what we've always gotten. It's so much easier to prevent disease than to treat full-blown disease. Thank you very much.
All right, good morning. Thank you, Carol. I think I'm going to be stealing the horse and the heart analogy. I loved that, and I come from some horse country out in California, so I think it'll really resonate with a lot of the people I see. I also want to say thank you to Arbor Pharmaceuticals, who provided the educational grant so we could all be here this morning, and a big thank you to all of you, because you're choosing to spend the coolest, I'm not saying cool, but the coolest time of the day with us, although I think it is still cooler in here. So it is an honor to be here speaking to you, because I know that you are the ones who are doing the work, and I hope that you get something out of the talk that you can take back and maybe incorporate into what you're doing already. So we'll spend the next 25 minutes talking about how the importance about supporting the prevention, as Carol mentioned, and the management of heart failure in women, because it does take a village. So the next two slides really go over data that you already know, statistics you know, but it is the reason we're here. We know that heart disease still continues to be the #1 killer of women in the United States. Nearly 43 million American women have or are at risk for heart disease. 1 in 4 women still die from heart disease. And when we look at racial and ethnic disparities, we know that African American women are at higher risk for cardiovascular disease, and that 1 in 3 Hispanic women have cardiovascular disease. And so more specifically around heart failure, when you look at 2.5 million women in the United States who currently have heart failure, we saw Carol's slides. We know that women are getting older, they live longer, they have a lot of risk factors, and they're going to continue to have more heart failure. So I say it's a little bit of job security for all of us in the room, but it's not necessarily the best thing for our healthcare system and the quality of life for our future generations. And when we look at prevalence, we see that about 1.8% of Caucasian women and Hispanic or Mexican American women have heart failure, and it jumps up to 3% of African American women. So we're obviously missing the boat there on prevention. As you know, you probably see this all the time. You see women, especially young women, who are misdiagnosed. How often do you see someone who gets an albuterol inhaler for 6 months before they actually get a diagnosis, right? We're giving them that nice beta stimulation. We're actually increasing their heart rate and probably making things worse. And as Carol mentioned, those SAD, the depression and anxiety components, women often get blown off because they think it's related to menopause or it's panic or stress. And we know that panic attacks are common and depression is more common in women, and that often masks what's actually happening with the heart. So again, some of this will be repeat, and I think Carol and I are a little bit, I hadn't met her before today. We work with some similar people, but we're all about prevention. I actually work very strongly with Preventive Cardiovascular Nurses Association, and I grew up with a dad who's a preventive cardiologist, so I kind of lived and breathed it. But we know that the typical heart failure patient is frail and elderly, has multiple comorbidities, and has cognitive difficulties. We also know that we need a team-based approach, and I think all of you can vouch for that. So I was voluntold into the heart failure readmission reduction team in about 2010, and this was really new for me. I'd been in internal medicine for years. I'd worked in cardiac rehab. I'd worked at the bedside, and I was back in the hospital, and we all kind of got that shock of, oh, the hospitals are responsible for readmissions. So when looking at kind of building what that team looked like, I did the reading with Eric Coleman and Mary Naylor and Project Red and Boost, and really the bottom line was you need this collaborative team. And I put the puzzle up there because, depending on which state you're in, which county, which hospital system, which hospital, your puzzle is going to look different than the other person's puzzle. So while we have kind of this general approach to building this collaborative team, how you build that team is going to be different everywhere. And I really think that, we even then get down to the patient level, and we say that every patient is an N of 1, right? So their puzzle is going to be totally different than the person with heart failure in the room next to them. So how we build that team and support that patient is very different. And I really think hospitalizations highlight that importance because they come in and then it's really exposing all the differences that they have. Again, kind of reiterating what Carol has said, but the typical female heart failure patient is older, linked more to hypertension, diabetes, valve disease, and probably undiagnosed, unrecognized coronary artery disease. They're hospitalized more frequently. They more often have HFpEF with less treatment options, survive longer than heart failure, so they'll be in our healthcare system for longer, so we'll probably see them more. They also have more shortness of breath and exercise intolerance, which brings them back to the ER and brings them back to the hospital and to your offices and clinics. And then again, we have different causes of heart failure than men do. Okay, so when I was putting this talk together, I wanted to come up with some great quote about women and men being different, and up popped this book. And so, do you guys remember when this came out? This came out in 1992, and I think being fully transparent, I was dating this guy back in 1994, and he was taking a women's studies class in our undergrad, and he thought that we should read this so that we'd have a good relationship. And we are married now. We've been married and together for over 20 years. I don't know if I credit it to this book, but I thought it was, that's probably why I picked this. But men are from Mars and women are from Venus. So I'm going to take kind of two stands here where women are different, and we do know that, and they have different needs, and they have different symptoms, and I think since 1992, we've had a lot come out now. I mean, we've done a good job. We have American Heart Association Go Red for Women. There's the Spread the Word campaign about a different presentation and different symptoms in women. We have the Heart Truth from the NIH, and we also have the Women Heart, which is really the specific kind of support group by women and for women with cardiovascular disease. So I think we're making strides, but I still think we need to make sure we pay attention to the differences in women. And going back to prevention, you guys we're not trying to convert you all to preventive cardiology practitioners, but I think education is so essential. And when I actually developed these slides and handed them in, we were really talking about hypertension, diabetes, and then undiagnosed cardiovascular disease. But if I were to do these slides today, I'd actually highlight obesity, and I want to talk about a couple things that came out this past month that I want to make sure you're aware of. But first, I think we talk about how we motivate patients, and I don't think we should try to scare everybody because we know that doesn't work, but I think really being honest about the risk of heart failure is extremely effective in our communication. So when you talk with women and they have hypertension, and you'd say that, if I took 2 of you and continue to not treat your blood pressure, one of you, if you were to, one of you would develop heart failure. And most everybody has some sort of kind of relationship with heart failure with a family member or someone they know who died of the congestion, or, they call it different things. But I think really important of doing a better job in our primary care settings, but also as secondary risk factors after they have either cardiovascular disease or heart failure, looking at how we're managing hypertension. And Carol did a great job talking about the increased risk for women who have diabetes, and then of course you add in smoking, and then you've just really pretty much guaranteed that they'll have cardiovascular disease. So going back to obesity, I'm not sure if you saw, there was a study published in JAMA back earlier this month, which showed that while obesity rates in men have pretty much plateaued since 2005 at 35%, women have now surpassed men, and 40% of US women are now obese. And what's scary is the number of women in that very obese category has increased even more. So I think obesity is somewhere where we're really going to have to focus around women, and especially with Hispanic and African American women, we see that too. The other thing that just came out last week, granted, this is in mice, so we have to, see what happens in women, but what they found was that in pregnant obese mice, they actually had genetic changes, genetic abnormalities in their mitochondria. So your mitochondria are passed down from your mom, so you get your mom's mitochondria, not your dad's. So what they found was that the mama mouse, who was pregnant and obese, ended up impacting the mitochondria for 3 generations. So their kids, their grandkids, and their great-grandkids. And those 3 generations were at increased risk for type 2 diabetes and cardiovascular disease, even when they fed those mice, I know not humans, but the mice were fed healthy diets and they were running on that hamster wheel. So they actually had a healthy lifestyle for these 3 generations, but despite that healthy lifestyle, they were still at risk for cardiovascular disease and type 2 diabetes. So again, I know it's in mice, but I thought that was fascinating. I mean, the choices you're making as a pregnant woman could impact your great-grandchildren, and I think as much as you love your children, I don't know, I see this with my mom, she loves my children even more than I think she loved me, right? So you think about the impact of the grandchildren. The other thing that's specific to women is we're really finding out a lot more about the future risk of pregnancy-induced hypertension, preeclampsia, gestational diabetes on future cardiovascular risk. And I think this is really interesting. I mean, the pregnant women and then the in utero impact. But you think about all the decisions a young mother makes, and that cascade impact on their family. They're the ones making a lot of the lifestyle choices, the diet choices. So if we can capture that audience, I mean, we talk about kind of primordial prevention, capture that pregnant women who have the pregnancy-induced hypertension and preeclampsia and get them into some lifestyle modification early, I think there's an opportunity to really make an impact on our future generations. Okay, so we talk about women being different, but I think Carol did a really good job of talking about we still have disparities. We still aren't getting women into the clinical trials. We're still not treating them the same. So I came across this journal supplement, which I didn't even know existed. It's actually the second annual edition, so it's only been around one other year. But Circulation in February does a women and cardiovascular specific supplement. And it is targeting research about women, but it's also targeting research by women, which I think is fabulous. And what he wrote here was, we will know we have achieved equity of opportunity within medicine when there's no longer a need to note the sex or race or ethnicity of authors, investigators, and leaders, especially among the upper tiers of science and clinical care. And what I didn't put in here is he goes on to say, we will also know we have arrived when we have enough data on women's health that is just commonplace and that we don't have to have an asterisk next to the data saying only 20% of women were in there. And then we'll really be addressing disparities. So these just came out again in February, and this was from Get With The Guidelines data, looking at almost 50,000 patients with acute MI, over 65, at 366 hospitals. And what they really kind of proved to what a lot of us already know is that women receive suboptimal care. But when they broke down that data, they were able to say that up to 70% of the disparity in mortality was actually related to that suboptimal care. And we're talking about stuff that's, for those of you who've done core measures and, we know what to give these patients after they've had an acute MI, but these women weren't getting aspirin within 24 hours, not getting counseling for smoking cessation, and not always prescribed medications that we know are commonplace, aspirin, statins, beta blocker, and ACE. So it's kind of ironic on a personal level. I was asked to do this talk, and then my mom went in the hospital, and she was septic, and she got really confused and delirious and paranoid, and it was really interesting. And she ended up started having ectopy, and she was a PE teacher and, kind of super strong heart. And they did an EKG, and she had ST elevation, and her troponins were up, but she wasn't having symptoms. Granted, she was also very paranoid, but she ended up having Takotsubo cardiomyopathy when they finally took her to the cath lab. But I live about 2 hours away from them, so I got the news. I said, okay, I'm coming down. So I drove down 2 hours. It took them 8 hours to give her any therapy because they said, well, she's not really having typical symptoms. And I was like, okay, well, she has ST elevation, and her troponins are 4.6. So, it was really interesting. I just, and I wonder if it was a man, and I hate to think that, but I wonder if it was a man, if they would have treated him differently. But they waited 8 hours to even get her a beta blocker or an aspirin. So now I got to explain to everybody in my family about Takotsubo, which was fun. My dad didn't even know about it. But then I sat there and watched her echo. I was like, yes, that's exactly it. That is what Takotsubo is. So now she's my case study. She doesn't know it yet. I'll get a disclosure from her later. So the other thing that I think is interesting when you look at women after an acute MI, so this was a study done in 1,600 patients and looking at the age group of 18 to 55, so kind of what we look at as our workforce years. Granted, a lot of us are still working or plan to work later than 55, but women were less likely to return to work than men. And I think it's really important to talk about, that's a huge indicator of future well-being, right? For independence of wealth, for socioeconomic status, and also just for that feeling of worth. And we also know that for any of us who've ever left the workforce, then re-entering back later is always much, much harder. What was interesting when they started to really analyze the data is that the women who were having heart attacks started off much sicker. So they started off at a more debilitated time when they had that acute MI. And then when women, and this won't probably surprise any of you, but after they were trying to return to work after their event, they had a higher burden of stress, more depression, more caregiving demands, and a greater burden of household duties than men. So I don't think that'll change anything, but I think it helps us really think about how do we then target our interventions after an event, after a hospital stay, to help them get back to work. Okay, this was just around hospital discharges for heart failure by gender, and you can see that there was a more greater divide in 95 and 2000, and so when women are from Venus and men are from Mars came out, but then it's really started to drop down. So we know rehospitalizations are still a big deal. That's probably a lot of why we're here and what we're learning, and you're hearing from a lot of the experts on this. But so I kind of want to take now, the tale of two books, right? So back in 1992, we were talking about them being different, and then this book popped up from So then this book popped up here. So this was a quote from George Carlin, the comedian, and that men are from Earth and women are from Earth, and we just need to deal with it. So goodbye, John Gray, and hello to just we're all from the same. And I think that's really, you could probably approach this from that side where we know that there's so many great interventions out there. We just aren't doing a really good job of giving them to the women. So we won't really know about the disparities until we actually treat women the same, and African American women and men and Hispanic American women and men, and we treat them, the same or with evidence-based interventions that we know work, and then we'll know if we, how much we're the same and how much we're different. So the Heart Failure Society of America, you guys know these guidelines probably inside and out. I remember when I was first doing this work, I kind of slept with them under my pillow and hoped the information would, go into my brain. But besides the medications and the guideline-directed therapy, they talk a lot about the transition process. And all of this is really important, and we just need to make sure we're doing this in the women. So promotion of self-care, again, enabling them, empowering them to do their own self-adjustment of diuretic therapy. And then with the vigilant follow-up is optimization and individualization of medical therapy, I think is really important, right? So making sure that if they need the Bidil, we're giving them Bidil, or if they're of pregnancy, bearing age, and then, or childbearing age, we need to give them the right medications. And I also think that when we talk about increased access to providers, if we're talking about a working woman who has kids, who has the morning kid duties and the afternoon kid duties, and the medical offices are open from 9 to 3 or 9 to 4, Monday through Friday, when are they ever going to make it into providers? So I think that, in our healthcare system, we're starting to look at evening appointments and making yourself available, or making, doing phone visits or telehealth visits. So I think that's really something important to think about, how you individualize that access to care. Early attention to signs and symptoms, both of fluid overload, but we talked about that also in prevention. So in fluid overload, a lot of times people feel anxious, right? Oftentimes they can't separate out that anxiety in the middle of the night versus being fluid overload and having PND. So making sure they pay attention and they don't just brush those symptoms under the rug like they have for years and may have been the reason they ended up with heart failure. And then again, assistance with social and financial concerns. I think, especially if we look at the information where women aren't returning to work and then don't have as much of that financial independence, how are we addressing those concerns around the medications? Are we making sure they can get the generics? Are we looking at how much their copays are, how many specialists they're going to, and how many times they're having to pay those copays? Because $10, over 15 visits a month plus all the medications can add up and be the difference between healthy food on the table and not. Also, for those of you who don't know, there's we talk about individualization, right? And if we talk every person's an N of one and men and women are different, there's some educational sheets that were actually developed in a collaborative project between American Association of Heart Failure Nurses and PCNA. And they're available on pcna.net, and you can actually download them. And they're available in English and Spanish. You can customize them to your own facility. We actually use them at our facility because I like the tear sheets, because then we can pick which ones we like. There are 5 of them. And they're actually has anybody heard of the Stronger Hearts Helpline in San Bernardino County? Have you guys heard of that? Yeah, through the National Forum. Great. So this is a program that's available. It's called Call 211. So people with heart failure in the community can call 211 and get information on resources and providers and wellness classes, and it's in bilingual, so it's English and Spanish, and they're actually using the Spanish version of these tear sheets. So if you haven't checked them out, they're again, they're wonderful. They're written at like a 3rd grade reading level, and they're very user friendly. Okay. So I do want to spend just a few minutes about what has worked for us in our program. So at our hospital, we started off with a heart failure readmission rate somewhere around 20-21%. And for the last 2 years, we've been running around 10 to 11%. So we've had significant success. And so hopefully you guys can take away something. And what I've done here is I put a little red heart to the right of the ones that I think have really, it was fun to go back and really think about the ones that actually impact women, and maybe the ones that, you could focus on for women. So again, managing risk factors. I think we've beaten that one to death a little bit, but really important about managing the risk factors in both either the primary care or the specialist follow-up, early identification of signs and symptoms, especially if, it's a tachycardia-induced cardiomyopathy. Are they aware that they're tachycardic? Or if it's related to CAD, are they addressing that angina and getting it addressed and getting the proper follow-up? We use transitional care management in our programs where you can get higher reimbursement. That's something that's been helpful, where they get the phone call follow-up within 48 hours and then the visit within 7 days. I think advanced care planning maybe start about 4 times in the next couple of slides. Because again, remember, the women are living longer, they're older, they come back to the hospital more. So how can we really give them what they need? And a lot of that is the discussion around advanced care planning. And I don't know if you guys are struggling the same as we are about where that discussion is best taking place. We're trying to do it in the hospital, maybe not the best place, but really having that conversation around what their goals of care are. And, there was somebody who even said what they wanted to do in their EHR is if somebody had heart failure is every single year they would have advanced care planning pop up as kind of like a best practice. And they would just do that advanced care planning discussion once a year. I thought that sounded like a wonderful idea. So our system does a lot of work with home health and skilled nursing facility. And actually yesterday morning we had our quarterly skilled nursing forum, and we have all the local skilled nursing kind of administrators come together. We have a group of about 80. We have home health come, and we meet with them. And we've done this now for about 3 or 4 years. And it's probably been one of the best ways for us to reduce heart failure readmissions, or just all readmissions to skilled nursing. So it used to be about 25% of our readmissions, and now it's about 10%. And it's all around the communication and the kind of having kind of a shared common goal. But a lot of what we emphasize is getting a social worker in there to really understand in the home, especially, they come in the hospital and it's this totally alternate reality. And then when they go back home to their real reality, we can't ever anticipate from the office or from the home or from the hospital what that looks like. So to get a social worker in the home and really have that discussion with them and kind of be in their presence and look around and go, wow, you're taking care of 7 of your grandchildren and 2 of your kids are living with you, and talking about really all those stressors. So we always get a nutritionist and a social worker on home health for our heart failure patients. And again, advanced care planning. So 2 other things is we have our disease telemanagement program and a heart failure clinic, but we actually changed the name to Heart Health Clinic because people would honestly not come to a clinic with the name failure in it. So we are now the Heart Health Clinic, and we do a lot of individualization of treatment and do a lot of motivational interviewing with these patients, both in the disease telemanagement program and heart failure, or in the Heart Health Clinic. And a lot of it is to try to individualize that practice by developing goals of care. So we also have foundation grants for education and funding for scales and blood pressure cuffs and pill boxes. But I think 2 of the programs that we have that have been really great for women is we actually have volunteers who come in the hospital, and their focus is providing support to the caregiver. So we identify our heart failure patients, and then they actually go in and meet with the caregivers and the families, and they're not clinicians. They're for volunteers who've had experience either with heart failure or taking care of a family member who has one. But that has been a wonderful addition, and they attend our monthly support group. So we have monthly support group with education and sharing, and it's usually about 75% women, and a lot of it's caregivers. But we talk about preventing Takotsubo in those caregivers. We might be helping with that, but also just providing extra support. We also developed a heart failure-specific class in our cardiac rehab program, sticking a woman who's 75 with heart failure in with a 40-year-old who just had an MI was a little bit challenging for them. So that is something else we've done, as well as more awareness campaigns for cardiovascular disease symptoms. Okay. So when we look at these two books, women are from Venus, men are from Mars. I always put the women one first, and my husband always laughs at me. Or the men are from Earth and women are from Earth, deal with it. I think there's something in the middle about how we approach our patients. I think we can take something from both of that. Yes, we need to approach women differently, but we also need to make sure we're treating women the same as men to know that we are giving them the best therapy. Okay, I think we have a few minutes for questions and answers.
If you guys have any questions, raise your hand and one of us will bring a mic over to you. So please ask questions away. Don't be shy.
Thank you so much. That was really practical and informative, both of you. Thank you so much. So I come from an urban, somewhat poor environment, and buying the $25 scale at Walmart is not always an option because it means they're not going to pay the electricity or something like that. And I have not found the foundations that you have to have that funding for people that need, or in one particular case, a gentleman needs $250 for a CPAP machine to extend to the 5-year requirement because it's broken, so he's just not using it. So those kind of patient needs, is there a list? I'm sure some people here must have a list of foundations or can steer me in the right direction so I can have some of these practical things to provide for our patients.
Yeah, I know Women Heart has a lot of resources. I'm on the scientific advisory board, so it's the largest it's a group dedicated to women living with heart disease, and they have a lot of resources and things like that on their website, womenheart.org. The other thing I found is I've actually talked to our health system about some patients. We're going to provide them a scale because that readmission is going to cost you, $100,000. That scale is going to cost you $25,000. What do you want to do? So I've actually been somewhat lucky to get them to agree with me on some of those things. And I think if you could find out whatever health system is sort of responsible for that, they should see the penny-wise, pound foolishness of not giving this poor person a scale.
Yeah, and I've even found that some of the less expensive scales are just as good. So I mean, we'll find scales for $12 to $14 on Amazon, and I know that's not much. I mean, but it adds up when you're talking about giving out the scales. But I think what Carol said is, if you find your partner who's motivated to reduce readmissions and really talk with them. Are you associated with the hospital system? Yeah. Yeah. Do they have a foundation within the hospital? You're not sure. Okay. You're still in that whole exploratory, finding out all the pieces to the puzzle, right? Yeah. So, well, good luck. And you can always feel free to email me and we can brainstorm.
Yeah.
Just to add on the scales, we actually put it in our budget for the clinic that we provide scales for anyone who needs it, because it just, originally we had a foundation that provided that, but then we were purchased by a for-profit agency and we couldn't do that anymore. And we just left it in our budget, and now we're getting ready to add blood pressure cuffs to our budget because we find that is so important to provide that. Do you have a scale? No, I don't. Can you get one? No, I can't. I can give you one. And that makes a huge difference.
It's a great idea.
Difference.
Perfect. My budget's up due in July, so I think I'm going to do that. Because you're right. You never know when those funds are going to dry out from a foundation.
Right.
So
It made all the difference in the world.
That's great.
I'm coming. Other questions?
It's not so much a question as just kind of following up on that. At our facility, our gift shops all the money goes back to the hospital for whatever needs that you can ask for. So our heart failure clinic, about every 4 years, we get 400 scales from the money that the volunteers raise from the gift shop.
Nice.
Right next to the candy they sell.
Yes. I have a question about getting insurances to pay for Biodil. We have a lot of difficulty even with requesting with prior auth. So does this bioequivalence determination from the FDA actually help in getting insurances to authorize that?
Right, so that's a really great question. So when we write guidelines and do things like that, we put specific things in there just for that purpose, so that insurance companies, they have sort of the fire to their feet. They're supposed to. What they do and what they're supposed to do isn't always the same. But certainly what we do, and because we're a referral center, we usually can get it approved, but it's a lot of hoops that we usually have to drop through, and I'd be happy to email me. I'll call on your behalf.
So I was wondering, as you were doing this research and the work that you do day to day, if you were able to identify any of the reasons why there's such a disparity and why these studies aren't focusing on women. In my personal experience with women, I've seen a lot of them who have refused the medications, who have wanted to try to do things homeopathically, who have already given up driving, and so transportation is a big issue. And so I'm just wondering if that's the same type of things you're seeing that are causing the disparities in the reports you were giving.
Yeah, I mean, those are all great points. I don't know that we know, and there have been so many studies trying to dissect it, because even when the FDA and the NIH mandated that equal numbers of women and men have to be enrolled and involved, it still hasn't happened. So I don't know. It's not going to be one easy thing, but all the things that you mentioned probably come into play. What do you think?
Yeah, I mean, I did research early on, and I remember in that whole recruitment phase, it was, you know, again, a lot of the times they would need to come in were during your standard work days, and so, you know, maybe it's going to take, I mean, I've seen some really successful research done on women in kind of South San Jose using nurses, and what they did is they just really had to insert themselves in the communities and go to the places where they were in order to get the enrollment. And so they had to meet them there rather than asking them to come in. But that's I mean, it's resource intensive, but that may be what we're going to have to do to meet these FDA requirements.
Yeah, so we have a large study at UCLA, about 1,200 participants, and we've had to do things like we have to provide Saturday clinics, we have to provide daycare, we have like a caregiver on site that can do that, and women are doing everything. So when you ask a woman to come in for their annual visit or their routine visit, they said, oh, but the goldfish needs caring for. Or, you know, everybody, there's so many things. There's, you know, the kids, the parents that many of them are caring for now, and there's work, and
Yeah, and you look at some of, I mean, kind of going over into transitions of care, you look at the really successful programs, and a lot of those programs are offering home visits. It's just having to go there versus making people come into one more appointment. I do have a big heart and these little mini figs, and I let the kids play with them, and I find mini figs in the hearts that I have, and then, you know, so I let the people bring in their kids when they come to the appointments, but still that's not always the answer.
Another question back here.
I was going to say, and what were your thoughts on the homeopathic question as well? The women that are just trying to take care of their symptoms themselves.
So one thing I tell every patient when I see them is, I promise you, I will not recommend anything to you that hasn't been proven by a large-scale clinical trial to make you feel better or make you live longer or prevent something really bad from happening. Because there's not really a good reason to do anything else. So if I'm going to order a test or I'm going to give a medication, it's going to fit those criteria. And then I say, I'll research this homeopathic preparation you want, and if I can't make it fit into this criteria, I can't recommend it.
Yeah, and I think I also look at the cost benefit. So I have people bring in all of their pills to their visits, and you know, it'll be like a ginormous box of all their herbal supplements and then, you know, their other pills, and they complain about taking so many pills. And so we go through and talk about the evidence really isn't there, and you're spending a lot of money, and you may be getting, you know, cinnamon in a pill that you think is, you know, it's not FDA regulated. So but I also think, you mean, when you talk about homeopathic, a huge advocate for lifestyle. So if they're using that in an effort to be healthier, then I never want to dissuade that. And I also want them to come back. So I'm very careful about how I approach it. So I think, again, I really encourage the evidence-based therapies and talk about the benefits and show the numbers of reduction in mortality and improvement. And then talk about how we can go ahead and try these other things, and if it's part of a comprehensive lifestyle change, then that's great. If it makes them feel better and it's not harming them or interfering with their medications, then I won't necessarily dissuade them. But really talking about it, it gets very expensive, and we don't know exactly what they're putting in their bodies with some of these therapies.
Okay, no question, but I have 2 comments. I'm from Kaiser Permanente in Fontana, California, and right next door to San Bernardino County.
Yeah.
And we are part of the Stronger Hearts helpline. And
great.
When they get a call from one of our members on Monday morning when we're back to work, they report back to us. One of your Kaiser patients called us with problems, and just want to let you know they're in San Bernardino County Hospital today. But if it's something that didn't need hospitalization, then we can follow up on Monday morning. But the other comment is we've had a transitional care program since 2007, and it's very robust. Our readmission rate before that program started was like 32%. I think it's now down to it's still high, it's like 22%, but a big drop. We made a lot of changes in it. Our first run through was a home health visit within 48 hours and a phone call from the outpatient case manager, myself, within 5 to 7 days. But we found out, of course, our frequent flyers, they're back in the hospital,
Sooner than that.
Sooner than that, 24 to 48 hours. So now our our phone call from me is 24 hours, and the home health visit is within 48 hours. And so that has made a big difference in our readmission rate, too.
And I think you make a great point about being comfortable with changing your process, right? If something changes and healthcare changes. And so I thank you for sharing. I think that's wonderful. And congratulations on the reduction, even though it's less, which is wonderful.
I just, again, wonderful talk. One type of cardiomyopathy that we didn't talk about was like the pregnancy-induced or postpartum, which I used to see 1 a year. This last year I've seen like 3 a year. And I think it brings a whole nother set of education about not getting pregnant again, and then if they're breastfeeding, volume issues with that. I mean, I've had a lot of challenges with that particular cardiomyopathy.
Yeah, so I did mention that. I'm sorry you didn't see that. But I agree completely with you. And I have to say, we have such a hard time with that. These are young, healthy women, and then boom, they just had a baby, and boom, they just got heart failure. And so many of them, it's such rock your world, talk about. And the medications that we need to give them are all contraindicated in women who are breastfeeding or nursing, and women who want to become pregnant again. And many of our women, these young women, do want to try to get pregnant again. So it's an important counseling and educational time for these women. Thank you for that comment.
Yeah. Any other questions?
There's one up here.
You could just shout it out. We'll hear you.
Nurses and pharmacists and your whole team. How often do you do that, and with your physicians peers?
So for us, it was very heavy in the beginning, and we did a lot in the kind of implementation of our program. We also offer education to our skilled nursing facility partner nurses, as well as the home health nurses, about every 2 years now. We'd like to do it more. And then all of our inpatient nurses go through mandatory training every 2 years, so they get it at least that much time. But then or they at least get it during that class session. Physicians, we do one of our kind of grand rounds a year is on heart failure, especially recently with all the updates, but about cardiomems and different things, we're always providing that. So, to women in heart. Oh, sorry. Of course. Yeah. Yeah, no, it's true. We incorporate it into our education, but it's not just women and heart disease. Yeah. Usually the education is when we get the 38-year-old woman with a LAD occlusion of 99%, and then there's a lot of talk that goes around the hospital around, so that's usually a one-off, yeah.
Thank you guys
Thank
for being
you.
a great audience.
Yeah.
Thank you for joining us today. Have a good rest of your day.